We'll go ahead and get started with Journal Club. My article is on improving duration of antibiotics for skin and soft tissue infections in pediatric urgent care. And so I work in the project with Dr. Fulton as my advisor, and we have no relevant financial disclosures or affiliations related to this presentation. All right, so who wrote this? So here's a breakdown of the various authors. The first author is Megan Hamner. She recently completed her pediatric ID fellowship at Children's Mercy Hospital in Kansas City. She's now at the University of Mississippi Medical Center, but this was all done during her time up at Children's Mercy while she was a fellow here. And then she's published several other articles, a lot of them in the Link newsletter, which talks about antimicrobial stewardship has been her big focus. And she has a bunch of other presentations on QI projects, again, mostly related to antimicrobial stewardship. You can see some of the other people here. A lot of them are related to the urgent care pediatricians, because this is where it took place in the urgent care centers. So that's where Dr. Nedved is, and Dr. Austin as well. And then you can see some of the rest of the team. Donna Wiley is a pediatric nurse practitioner. She's also published on stewardship for acute ear infections, which I thought was relevant to hear in this discussion. And then we have the pharmacist, as well as some other hospitalists and other people helping out. And then at the bottom here, Dr. Thayali. She is a PID doctor, and she was a main mentor, it sounds like, for Dr. Hamner and helped a lot with the project development. And she's also in charge of that outpatient stewardship program. All right. No external funding was used for this project, so it was all self-funded. And if you guys read through it, there's not a lot of stuff that really needed funding here. It's really more time than anything that went into the study here. All right, so why is this study important, and why do they want to look at stewardship more? There was a study, a 2010 paper in JAMA, that talked about how half of antibiotic prescriptions were inappropriate for one reason or another, whether it was the wrong antibiotic, the wrong duration, or the wrong route, or the wrong formulation. So a lot of prescriptions are not optimized. Now, it doesn't necessarily mean it won't cover what you think, but it's just not following the guidelines for a maximized therapy. Not saying that half of a prescription right is not going to cure the people, but it's just not optimized. There was a 2017 article looking at about 3,000 prescriptions, and it said that 30% of pediatric prescriptions are exceeding the guideline rate. So even pediatrics, we just look at the one factor that can lead to being wrong. A third of prescriptions were the wrong duration. And then why did they look at skin and soft tissue? It's the second most common reason for antibiotics to be prescribed in the outpatient setting. Number one is, what is it?
Respiratory illness?
Yeah, respiratory illness, and that includes ear infections and things like that. So those would be kind of your number one. So this is number two, but as you can imagine, most people doing studies, number one, we're going to focus on that one. Well, that means that number two might mean you have more room for improvement the less people are focused on it and less people have done work on it. All right, so then this talks about the IDSA guidelines, so Infectious Disease Society of America. The 2015 guidelines recommend 5 to 7 day courses for common infections of skin and soft tissue. Now, that doesn't mean 5 to 7 for all of them, right? So some of them are 5 days and some of them are 7 days. But with that being said, 5 to 7 days is going to cover you for most of these. Does anybody know, like, abscesses, how long it should be? 5 or 7?
5.
5.
Oh.
Yeah. So recurrent abscesses, you could go up to 10, like a 5 to 10 day course. And then sometimes, too, if it's very superficial and you do an irrigation and drainage, you might not actually have to do any. But 5 days would be a good place to start. How about cellulitis?
5.
Good. All right. And then how about something like erysipelas?
5.
Right, and then how about impetigo?
5.
7. So that's what I'm saying. It's 5 to 7. So not all of them are the same, but there you go. All right. And then here's a study from 2018 looking at 10,000 pediatric encounters for bites as well as skin and soft tissue infections. And 70% of prescriptions were for 10 days, right? Now, what did we just say for most of these is going to be good? 5 to 7, right? So now we're talking 70% for 10 days. That's a lot of unnecessary days of antibiotics there. Bite wounds in particular, it can even be rather shorter. 3 to 5 days is actually sometimes okay for that one instead of getting the full 7. Now, when they look at the different prescriber classes, so they looked at family med, nurse practitioners, as well as pediatricians, they found that pediatricians were more likely to use the correct first-line agent, right? So using Cathalex for a non-purulent infection, or like clindamycin for a purulent infection. However, they also tended to go on the longer side for duration of treatment. So they tended to be the 10-day prescribers as opposed to some of the shorter ones like family practice or other emergency room providers and things like that. All right, so that's the why behind this study. And then They did a study site here, showed that 60% of the prescriptions had appropriate dosage. That's maybe a little bit better than some of the other ones where the 70% were inappropriate, but that still showed a good bit of room for improvement. All right, so where is this? Again, we kind of talked about it a little bit. It's at the 3 urgent care centers associated with Children's Mercy Hospital. At these 3 centers, they have more than 90,000 encounters a year, so they're pretty busy urgent care centers. It is unique, I think, among some centers that they actually have dedicated pediatric urgent care centers and staffed by pediatric providers, as opposed to just being like a general outpatient urgent care where they take everyone in. That's not to say they're not associated with adult centers, but they have dedicated space, kind of like our ED does. All right, so looking at the population, they looked at people 90 days old up to 21 years with skin and soft tissue infections at their discharge site. So these aren't people admitted to the hospital, but discharged from the urgent care setting. They looked at the cellulitis, erysipelas, abscesses, and impetigo. It also includes kind of the folliculitis and then the nail infections as well, and animal bites. They excluded patients who they sent directly to the ED on that first visit, people with concomitant infectious illness. And why do you think they did this?
They're going to get maybe longer treatment.
Right, they might get different, right? So if they have a strep throat and they have a skin infection, right, we're going to treat them with 10 days for the strep throat, so we can't have them in there screwing up the data. And then patients not receiving systemic antibiotics, so people who would just treat it with topical creams, or maybe they did IND and then sent them home, those were not included as well. All right, so how well does this then apply to our population? If you're thinking about, an urgent care center in Kansas City versus here.
I think it'll carry over pretty well. If anything, they might see worse cases than we can see here.
Yeah. So, I think that they probably see a lot more patients in their center than we do here, but otherwise, I think, skin and soft tissue infections don't show big variation in geography. If you go out west, in some places you can have some fungal infections causing a few more skin things, but overall they should be pretty similar in terms of the epidemiology behind this stuff.
How does the antibiogram there compared here, though, right? Like, are we prescribing wildly different antibiotics for these skin infections?
So, we don't have great data. Even here, if you look at the pediatric ones, they take a while for the antibiograms to get updated. And for the first-line treatment, right, so Caflex is still going to be great for non-purulent infections in both places. And they actually broke through, and if you go through the supplemental info, I don't have the exact differences on like Clinda and MRSA susceptibility per se. But again, that really should influence more your choice of agent, not necessarily duration as much either. But good thought. All right. So here's a breakdown of their patient population while we're talking about kind of where they're working. So they had about 5,000, a little over that, patients total. When we look at their first side, that's looking at really the baseline data and breaks down, those 2,000 patients that they end up including from that. And it breaks down why people were excluded, right? And it's those same criteria we already talked about. It's sent to the ED, they weren't old enough, they didn't have systemic antibiotics, or they only had topical, and then they had other infections that they were treating. Then here's a breakdown of the infections that they're seeing. So a lot of impetigo, cellulitis, and abscesses. And then the other category includes all those, bites, the nail infections, and those kind of things. And then we look on the other side, right? So looking at the time period, it's a longer time period right now. So, right, we went from a 1-year time period to 18 months, and to get about the same number of patients, at 2,700 patients there. Similar numbers were excluded, and we have a similar breakdown in terms of which infections they were treating there. A little bit lower in the other category, but again, pretty similar there. Does anyone want to think why it took longer to get more patients? Why it took 18 months?
COVID, so kids were like less active and doing stuff outside.
Yeah.
And
so they talked about how COVID came out, and that kind of messed up the data, right? Because it's a big drop off there. All right, so when did this take place? This kind of talked about a little bit on the last one. They had the 1-year baseline data, that June 2019 to June 2020, and then they had monthly data reports that they were kind of looking at from July 2020 to December 2021. From October 2022 to 2020, to December 2021, they maintained a provider-specific dashboard. So that's one of their interventions was. That's one of the time frames there. And then they collected post-data up through May 2022. I suspect it's May 2022 because that's when she was leaving her fellowship, and they had to wrap things up, so she had a month to finish it before she was done. There. All right, so how did they do this? This was a QI with PDSA cycles. They did 3 cycles throughout the study. Here's their aim statement, right? To increase the percentage of patients receiving 5 to 7 days of oral antibiotics in pediatric urgent care centers for SSTIs from 60% to 75% by December 31st of 2021. So is this a smart aim?
Yes.
And why is it?
Specific and action.
Yeah, so what does the SMART stand for?
Specific.
Measurable. What's the A?
Actionable?
Or attainable.
Attainable.
Yeah. What's your R?
Reasonable.
Reliable.
What?
Realistic.
Realistic, yeah, there you go. And then what's the T?
Time sensitive.
Yeah, so timely, right? So they have their time aligned on here, right? Okay, good. All right, so to start it off, they also surveyed 50 providers in these urgent care centers. About half of them responded to identify barriers. So this was purely just trying to get ideas, where are things going wrong, how can we help you guys out better, and what is going to be the issues there. And then they also did a cause and effect analysis. So looking at specific answers, like what led to this person getting a longer dose, what led to duration, what was influencing duration on different patients, to try to figure out where the breakdowns were happening. And then they identified their key drivers and create a prioritization matrix. So really just saying, okay, here's what seems like the number one easy thing for us to target now. Here's the next things that we can target down the road and other ideas we have that way. All right, so, well, kind of breaking, while we go through some of their figures, we're also going to do a review of some of the tools. I believe Dr. Dean gave us this talk to the residents about how to do different, using different tools especially. So here's their first diagram. It's the Fishbone diagram, also known as the diagram. So you can see it's broken down into different categories here, and all showing how they have influence on the ultimate duration of antibiotics being prescribed. So we have the knowledge set up, right? Limited time to look up things. They have readily available references. They're just going off, you know, I don't know what the guideline is exactly, but 10 days should cover it, so I'm just going to throw 10 days in there. Then they also talked about technology, right? Is it harder to, you know, go for the EHRs that create more work for them in the EHR to shorten the duration? Is the EHR making it look like 10 days is the correct duration there? And then they also talked about relying on experience, right? So again, not necessarily just going off the literature, but saying, hey, here's what's worked in the past. Here's what I've always done. I'm not comfortable doing this. When I trained, someone told me X, Y, Z, never do this because X has happened in the past to them. So just being careful of that, being aware of those biases, the recency biases, and those kind of things. And then looking at patient outcomes, right? You know, this patient's extra sick. I'm not going to trust to only give them 5 days when they have a history of abscesses in the past and all these things. Looking at the urgent care environment, right? So there they don't have the benefit of always being able to look through the EHR and see every well visit and every prescription that's been given. If they just show up out of nowhere, they've never met the patient before. Looking at the communication as well. So that's the kind of the cause and effect analysis. Any thoughts on this? Questions about how it's set up? Sounds good. So then here's this figure came out of the Simpson et al. Recent article in Pediatric Review talking about how to do QI research. And this just breaks down an example of how you kind of look about setting up your key drivers. Right? So these key drivers are going to be the things that you identify in your failure mode analysis or your cause and effect analysis of why problems are happening, right? What is it? Is it that technology? Is it that knowledge? Is it because, you know, the EHR system doesn't make it easy for them to do it all? Those key drivers are what you're seeing in your failure mode analysis that really point out the problem. And then your interventions get tied to one or more of these key drivers, so it doesn't have to just be a unilateral thing. And then you break it down by, you know, the order you want to proceed through. So in PSA 1, you might look at the first two. Here's the two interventions we're going to try, and it's going to target these key drivers. And then you can look and see if that worked. Do you need another intervention to target the same ones or target a new driver? Did it work on one of the drivers but not the other, and those kind of things. That's really how you can work through these different types of tools and think about possible interventions and ways to go about targeting the problem at hand. All right, and so here's the key driver diagram that came from their article itself. So you can see on the left, you have the aim statement there, and the key drivers they really focused on here was the technology tools, provider education, staff engagement, and then the patient and the family also getting them involved. And they had some secondary drivers here, right? So these are really interventions, is the other way to think about this, right? Updating the EHR, standardizing the prescription folders, and I think prescription folders is a term they use a lot here, but I think of it just like an order set essentially, right? And it's kind of like, or your favorite list, your preference list on your order set. So it's really that selection, pre-selection of your orders there. Working creating the algorithm, that's in the supplemental information if you're curious for it. Work through what infection do they have, and then which antibiotic and how long you would need to do it. And then providing education. They also worked on engaging people, right? So for engagement, keeping people informed of what you're doing and showing them the progress that's being made makes people want to keep pushing it towards that goal. So having the frequent reminders about how things are going keeps people engaged. And they also did some different check-ins and things like that to keep people engaged. And then they talked about making sure the patients are on board, right? So having the standardized discharge instructions, having that easy smart phrase so everybody can be on the same page there, and having that information so that way they're not like, well, I used to always get 10 days, now you only give me 5 days. And that can help with the pressure curves that way. All right. Then the next one I want to talk about is a run chart, which is a statistical process control, or an SPC graph. So runs we kind of talked about, I know during a previous QI lecture, but you have the shifts, so 6 to 8 points above or below median. The trend is going to be 6 with all of them going up or all of them coming down. And then you can have too many or too few runs, which shows you that they is either non-random or you didn't really have any effect there. SPC adds a few things there. So here they say 8 points above or below median. Now that's somewhat variable. Control limits would be data that's more than 3 standard deviations from the mean. Often shows that there's something different going on in that data that's probably not related then to the study itself. Something else happened. You know, if you think back when COVID came out, there's probably lots of things, if you looked at a bunch of run charts, lots of things changed. And that's just because there's something external going on. Here they also talk about zigzags. So if you have alternating points for a long time, that shows you have low variability of your data, which is showing you're getting towards a steady state. So you're no longer seeing accurate changes happening. It's pretty much leveled off your intervention's effect there. And then you can have different things here. So you can have 12 or 14 on the same side of the mean, so again, showing that there's something going on here that's depressing you from what it looks like. The 1/3 and 2/3 rules are also new to these because these, again, based on your standard deviations. So it's 1/3 of that control limit or 1 standard deviation from the mean. And so those can be useful, again, pointing out things where something's different happening in here. Those would be points you want to look at a little bit more closely and see what's going on here. So for examples, here's 2 that came out of that PDSA review article again. The run chart you see here shows the same data, and then you have the SPC chart on the other side here. You can see the added dashed lines are showing you those control limits that you have here. Again, it kind of tells you, you know, within this range, it's expected to be random. If it had something pop out of that, that would be different. So what are those rules used for? Those rules really tell you when you can change that line, right? So that line's flat, and then it jumps down, and then it jumps back up. When we drop those lines down, it's based on those rules that we talked about with the trends and the runs. So that's where those decision points are being made and how we decide those lines are going to be there. Questions about these before I show you the one that they used in the study? All right, so the one they used, I guess we got the PDSA one. Now I guess we'll talk for it. So PDSA 1, they did provide education for 15-minute didactics. They're pretty short. Just talked to them quickly and gave information on what those IDSA guidelines are. And so that ran from October to January. February to August, they used technology, so they pre-populated durations in that EHR in those prescribing folders, and then they also had it so that you'd have to scroll to select that 10-day option. So put an extra step on you if you really wanted to do a longer antibiotic, so push people towards the short durations in that case. And then in the last PSA cycle from September to December, they really focused on that engagement piece, really sending out those emails reminding people what the goal was and how they were doing towards that goal. All right, so here is their chart. Now, if you look at this, what's different about this one than the SPC chart we showed earlier?
A longer period of time?
Well, so it is longer, but if we look at the control limits themselves, right? So the control limits here vary based on the data points, right? It's not like it's consistent, flat line like we had on the other graph. And that's because this is actually a short chart, so SHEWART. It's a little bit, it's a variation, but essentially it still works the same way as the SPC does. It's just that they calculate those control limits at different points in a different way, slightly. But overall, it is most similar to that SPC chart. So you can see through it, right? They also have it annotated really usefully, right? You can see the background data that first year. Then you have that PSA cycle 1 where you see that first big change in that baseline. And then during PSA 2, you see again another change in that baseline where you're looking at that graph there. But we don't see 3 different interventions with 3 different cycles here, right? We don't see 3 jumps in that middle line there. Why do you guys think that is?
Okay, what was the question again?
So, right, there's 3 PDSA cycles, but we only have 2 jumps in the line, right? So we have the baseline, then we have 1 jump, then we have a second jump. Why don't we have 3 jumps or 3 PDSA cycles?
Was it that we were already like high enough that we were reaching our limit on what we were going to get?
Right. So remember, these lines aren't based on what you do, it's based on what the data is telling you, right? So like you're saying, right, once we got up to that second jump, we pretty much were at our goal, right? And we were just pretty much maintaining that. We didn't have a lot of room to go up, and we didn't see a big difference from PDSA cycle 3 in the data. We didn't see a huge jump. We do see a couple of points jumped up, but overall, it wasn't a huge difference in there. So again, that's just back on the point that those lines are not based on what you do, it's based on what the data shows you. And so overall, though, what's that?
I have one question real quick. With you're saying that there's a previous SPC chart, and you're saying that this is different. My understanding is this is a type of SPC chart, that it's a
Yes.
this E chart, and then there can be like U charts and G charts and stuff. So they're all SPC. Is that your understanding?
Yes, it is. Yeah, this is just a different one. This is the short chart, and it is slightly different, but from the one I showed earlier. But they're both SPC charts. Yes.
Okay, gotcha.
All right. So, we also look too, right? We see when the team was formed, right? And it looks like there was a little bit of a jump there. And then we have a provider survey as well, showing that some things might have jumped up a little bit there, but even though it wasn't big enough to count as a true trend. What do you guys make of that? I'm talking about right in here.
Is that maybe just a bump from engagement, like people even just thinking about and hearing about the project, they're going to be more conscious of their prescribing practices?
Exactly, yeah. So you can get like a pre-intervention planning effect, which is very common in QI products, right? Once everybody in the program, hears about it, you send out the survey, everybody's knowing that you're looking at it, people will be more cognizant, and they might, double check the references next time or something like that, because it's something that puts it on their radar. So that's a good point there. All right, any other questions about this chart? This is the key graph from here. All right, overall, do you think this is a good change, or did it look like they met their goal, or how did it look like they did?
It's pretty good. 25-30% increases, especially when it was already pretty high, is not bad at all.
Yeah,
They exceeded their goal.
Yeah. So perfect. All right. And so now we get into the so what. We can have a little bit more discussion, right? So did they meet their goal, right? And they did for this study. Then the next question I think I have is this something that would make us want to change how we do things?
What are our rates?
We can talk about that in a little bit, but we don't have great data on that at the moment.
Well, at the very least, it could make us change by making us want to examine those rates
Sure.
and see how we're doing comparatively, yeah.
Yeah. And then do you think their approach would work here?
Do you mean in terms of giving a lecture?
Like in terms of like running a QI project, doing maybe some of those things they did, looking at giving didactics, working engagement, would those things work? Carilion?
I think it might. We already do all of that stuff, so incorporating it, yeah.
Yeah. One thing they do talk about there of doing QI projects, right? So everybody is kind of on board to try QI things. I think for the most part, people here would be willing to try things, but I don't know if they're in the mindset is necessarily quite the same as it is there. This center that really is keyed up to do a lot of QI projects. It's hard to get people to change things, and it's easy to get people, on board with saying, yeah, we should do the appropriate things here, but then it doesn't always necessarily translate, I think, 100%. So I think having that infrastructure and that culture of, yeah, we're going to be doing lots of QI, we're willing to challenge ways we've done things is important. All right.
So sorry, what I'm noticing too is like one of the bigger differences is that they're in an urgent care setting, and it seems like a lot of their fear was driven by lack of follow-up, right? Like, oh, I might as well give 10 so that just in case, because they look pretty severe. But I mean, we're in a primary care setting here for the most part, right? If you're talking about Tanglewood, like these are kids that we can see again. So I think if anything, we should even be stronger on some of these prescription things because we have less of that doubt. We can have these kids follow up.
Yeah, a lot of the challenges that urgent care has we're not the primary medical home for these people, when you look through that Fishbone diagram that they did. And I think a lot of those might not necessarily apply to us here. That said, I think we all have patients that we've seen in clinic, and then they go to urgent care or the ED every time, they need to be seen acutely as opposed to coming back and seeing us. So I think that's, a challenge both ways, but I think having that history at least, and having all of our stuff pretty much in one EHR unless they go to Lewis Gale or something like that, makes it easier to see to that past history for us. All right. couple more things before we go on. But so here's some pictures that came off the sandbox Epic, some screenshots of our Caplex. So if you try to order the Caplex capsule, this is what it auto-populates, right? That 500 milligram capsule. What jumps out to you guys?
10 days.
Right. And so when is 10 days of Caplex a good idea? So if you're treating like strep, right, where someone has a penicillin resistance and you can't use amoxicillin, right, 10 days would be good. But most times we're using Caplex, what do we use it for?
Skin and soft tissue stuff.
Mm-hmm. And so that's really talking about how very few of those should really be treated for a full 10 days. So our EHR might not be saying it's for success. Now this did come off the sandbox, not the live version of Epic. So what's missing here that you probably see whenever you open up Epic is your Lexi Comp and all of those, which do have pretty good guidelines in there that's pretty accurate. So you do have that option, at least on the live version, that you don't have with the sandbox version. Now say you want to do the liquid though, because we're talking kids here, okay, we're going to do the liquid, and we're going to be starting there. What do we notice here?
Choose your own destiny.
Right, so you get to pick your own here, so it's not going to give you that. But if you look at the default supply again, right, what's it giving you as your default supply? Right, 10 days. So it doesn't tell you the duration is 10 days, but it's also not necessarily saying, if you say, oh, okay, 10 days at top of that, that sounds right. That's what I would do for strep, so let's just throw it in there.
How about your frequency? How often do you dose QID meds?
It's a lot of work.
Not very
Little as
In the
I
hospital.
possibly can.
IV.
Least often as I can.
The number of patients that I see from urgent care that has QID meds is a lot, because it's already QID.
Try to avoid those, especially like, even like clindamycin, when you do that, right? The default's going to be every 4 hours for that. But and you want potentially 40 mg per kg per day, right, for most things. Some things you can go away with just 20, but that's going to default to be 10 mg per kg per dose 4 times a day is going to give you that 40. But if you just make it, your 13 mg per kg and then drop it down to 30, it also still covers them pretty well. So that's going to be easier for compliance sake. All right, so here's some data. Now this is not to be taken as formal, publishable data or anything like that. This is just for QI planning purposes that's included here. If you guys were interested in starting your own study here. So definitely not going to be trying to rely on too much. But there's a database out there that looks at our patient population that you can get access to through the heart team and work with. And it can look at how often things are showing up. So I tried to look through those to see how we are doing. And we're not able to see duration of treatment in here. They have a category for time on treatment based on how clinics support the database, but it's not based on the actual prescription. It's based on how many times it shows up in their medical record and things like that, or if they switch therapies there. But when we look at the common ICD-10 codes for abscess use, cellulitis, looking through those kind of things, adding in the impetigo erysipelas, all those in there, we can see that there were 320 patients in the health system over the last year that had treatment for that and were prescribed Caplex within a week, or the same day of, or up to a week after that diagnosis. The people who are getting treated, essentially assuming for that skin soft tissue infection. This breakdown shows where people were seen for those. They still talk about Jefferson Plaza, even though last year, of course, Jefferson Plaza didn't see anyone. That's really talking about over here, but something that's still lagging there just a little bit. So a lot of these patients are seen at Serum H, Postal, and Velocity Care, as well as then the other main pediatric clinics. Rocky Mountain is very low down here. All these numbers are going to be rounded up to the nearest 10, so that's why down here. And if you look at this, right, now I said 320, right, and this is clearly more than 320 patients listed here. But that's because if they were seen anywhere at any of these, at any time at any of these centers over that year, they're considered a patient of that center. So that's just looking at the number of people at that center that have that. But 320 patients, that's pretty much one every weekday of getting diagnosed with a skin soft tissue infection and being treated with Caplex. So that's pretty much one every weekday in the current system, at least. So it does affect our population a good bit. And this is just looking at, again, Caplex prescriptions. So just to give you an idea of how common it is, but we don't know the duration here. And then this is not any kind of formal data. It's just really there if you were interested in your QI project, what you could find out quickly. All right, so any open discussion? What limitations do you guys see with what they were doing? What are some strengths of it? What other thoughts do you guys have? Not all at once.
I think especially in an urgent care where there is a big emphasis on speed, right? There's going to be a ton of patients. You just need to get through them. Tackling that point of making the path of least resistance correct prescribing, right? Making it automatically populate in the EMR, I think was a really good idea. It seemed like it worked pretty well.
Right, and if you kind of look back, right, when they had that technology, well, that did seem to be one of the pretty good jump there. One thing they noticed that a lot of people weren't going through the order sets or going through the folders, as they call them. So that's something that they worked on and did see a benefit throughout the study as well. I think it's also important to consider with these studies, right? So what are the downsides of this doing, right? So that's where in QI the subject of balancing measures comes up, right? So did they have a balancing measure that they talked about in the paper? Does anybody remember what that balancing measure was? Right, so when they were looking at their balancing measure, it was really return visits to the urgent care, right? So did people have to come back at the end of that, treatment course and get another treatment course, or did they fail treatment? They talk about how that might be limited, right? If people went to the ED or their primary care doctors instead of coming back to urgent care, they missed those and that. But when they looked at that, right, they didn't see a big jump or any real change in it. It was like 1 or 2%, I believe, if I had that number right on the top of my head. Who ended up coming back, which was pretty much the same across the study period. So no big change in people coming back.
Do they have access to like local ED or like primary care records? Like, have they access?
They didn't have the chance to look through those for this study, at least.
So that's a.
So what other limitations? What is the money? Yes,
that's a good point, though. That bringing up is that these patients could have actually had failure and went to a Med Express or a different urgent care and gotten their care. Or maybe they went traveling, they went on vacation. This is a quality paper, and it's not really powered and aimed towards looking at patient-centered outcomes. This is more looking at prescription writing outcomes within the urgent care practice. And so it's really not designed to look at your treatment failures and stuff. And what it looks like they did is just describe them. And so I'd be cautious in making the assumption that by doing this, our treatment failures are going to be pretty similar. This isn't this type of study to show that. And what it looks like they've done is they've referenced those guidelines from 2014 from infectious disease. And I saw this and I was curious, like, if they're making this big of a deal on this study, what are those guidelines actually saying? And it seems to be moderate to high level of evidence, especially for the cellulitis. My one question was, David, with the abscesses, did they specify if there was surgical intervention on those or not? Because that could really throw off whether there's treatment failure or not if you had it big enough to where you would train it and or treat.
Yeah.
The guy, it looks like you're supposed to lance purulent abscesses, and then if they have failure issues, then to treat. If I read those right.
Yeah, no, and I think that's a great point that you bring up. And no, they didn't really break down the other treatment, right? Because if they lanced it and drained it, not all of them needed antibiotics, so they wouldn't necessarily be included in this study then. So they really didn't break that down well, I think, from when I was looking through it. But I think that is a good point, too, about reading too much into it in terms of patient safety or patient outcomes.
It relies a lot on the strength of pre-existing studies supporting the 5-day duration.
Yeah, and then the 7, it was because they did put the 7. They wanted to make sure, and the guidelines do say that about 7 for, is it the impetigo, David? It's more than 5, and they said there was no change in outcome with that.
Right, but that's something I noticed that people were prescribing 5 for the one that was recommended to give 7 a lot more after they started the study.
And they may be right. It's just this is not the study to show that you can get by with shorter 5 days for impetigo as compared to 7. They may be right, but it's just not really designed that way. This is quality research for prescription changing, practice. And it looks like it was fairly successful for them, especially that chart you showed. I mean, that's what got them published, showing that P chart. I mean, that was very pretty and impressive. But those are my thoughts on it.
Thank you, Dr. Ward. Yeah.
I guess I would be interested to know, just based on what seems to be more anecdotal than actual data that I've seen, mostly probably because I haven't seen the data, if we broke down the prescribing practices further based on type of provider, So, you
And
know,
that's what that I think getting that first study looked at, where the pediatricians were more likely to pick the correct antibiotic, but they also tended to have durations that were too long. If that's what you're talking about.
I mean, NP versus PA
Mhm.
versus, yeah.
Yeah, that's what they kind of looked at there too, looking at those pediatricians. So, I think that it isn't really what this one's looking at, but some of that the background studies do talk about it a little bit, like the one that talked about pediatricians versus the other providers and things like that.
And I wonder if you would have an even more robust change if you did just look at some of those subsets of groups.
I guess yeah, I was trying to think about. I just don't know. I mean, overall, right, they had their goal and they were able to reach it. So I think everybody being kind about it, regardless of who you are, is important. There might have been some people that were doing, 100% of the prescriptions correctly, but as a system, right, they're really looking at the systems-based processes there. But yeah, that's definitely something to do, especially if you're not hitting the goals you want, right? Then you can maybe look at it and see who's not, right? Where are we having problems, right? Where are we not seeing that we really want? I think that's a good point there, especially if things weren't going well.
And on that same note, if things weren't being met, like being careful not to make it a punitive process, but rather a
Right, exactly.
mutual benefit.
And they had talked about having an individual provider dashboard where they were going to track each person individually and show them how they did, what percentage they were hitting. They ended up never rolling that out. They talked about a study because they were hitting their goal already. That was definitely something they had considered doing, where it would be on a personal basis, right? Just here's how you're doing it, maybe putting like the average of the group there. So that was something that they had definitely considered doing.
Did they do anything for accessibility of resources, or was it really just focused on that like initial education period, that 15-minute talk, and then from there on mostly like technology
So they
changes?
did create an algorithm to help with that. So that's actually in the supplemental. If I didn't include it here, but if you go through the supplemental stuff on the online version of it, you actually see the big flow chart, which they would then had as a reference that people could use, breaking down the different types of infections and how long to treat them and with what. So they do have that, and it's in their supplemental information. All right. Well, I have a couple quick questions, unless anyone else has anything they want to talk about during this. All right. So
Hey, David, and
here's the first
wanted
one. Oh, yeah.
to lay into kind of to what she was saying too, is that, if we assume, the guidelines are what they are, but, the true evidence base, at least the three principles are what the guidelines say, what the literature, the clinician's experience. And so there may be some instances where the clinician feels like a longer duration actually may be warranted, that maybe this is a little bit more complicated, or depending on an area of the body that's a little tougher to heal, like shins, or if it's closer to the eye, those sort of things. That may influence the clinician's decision, and then also the shared decision making. And so it's just because the guidelines say that doesn't mean it's necessarily, in stone, especially with several of those types of soft tissues. Those are moderate evidence. And so new studies can definitely change those recommendations when they redo them in the next couple of years. I think they're due in 2025 or so.
Yeah, absolutely. And I think that's a good reason too, right? With these QI studies, I think you should never pick 100% compliance with guidelines as your goal from a QI study, right? Because again, there are times where you need to go against the guidelines or treat patients a little bit differently, right? You can't treat everyone like they're just a number in the process, and some kids, you might have to treat a little bit differently than others. So that's why I think it's also important to keep that in mind. All right. So here's just some quick questions from the Peds Review article talking about QI stuff. These are pretty easy, and then you can kind of go through those. So the first one, you designed a new water safety counseling tool that you want to implement at well checks. Parents are reluctant for yet another screening tool. And then on a survey of families, 40% received this water safety counseling at baseline before you implement the tool. Which of the following is a well-framed aim statement? So increasing the water safety counseling from 40 to 75%, increasing from 40 to 70% for children aged 0 to 10, increasing in the visits from ages 0 to 10 from 40 to 75% after 1 year, increasing WSC to 70%, or just increasing the water safety counseling overall.
See?
Right, that's the only smart aim here, yeah. Good. All right, using that same project, what is an example of a process measure that aligns with your project's aim statement? So handing out water safety materials, having families respond to surveys on their water safety knowledge, increasing the number of families counseled for help supervision visits from baseline, measure use of an online tool, or tracking counseling time over several PDSA cycles.
E?
What was that?
E?
E? Yeah, vote for E. All right, and there you go. That's the correct one, right? So, you do want to increase the number of patients counseled, but that's not really going to be a process measure. That's more your outcome measure there. All right. Which of the following is a balancing measure? Increased administrative time for physicians, increase in visit time per patient, number of well-child checks in a day, physician burnout, and total number of patients seen per day, including child checks as well as sick visits.
B?
B.
Okay.
So B would be a balancing measure here, right? So increased administrative time definitely is something to consider. However, based on how they were thinking of the tool, right, the visit time per patient is really what's going to be more pertinent to having them have to do more counseling per visit. And there wasn't really an administrative burden here, but that definitely could be for some other projects. All right, and then which is an example of a primary key driver for this project? So you have the AP Bright Future Guideline, the data management knowledge, the drowning prevention education knowledge, provider-patient collaboration and knowledge of clinical counseling strategies, and a QI primary core knowledge.
Is that A?
You have a couple votes here. So it is going to be your D here. So here, right, definitely a guideline should never be your driver, right? So the guidelines are the driver. The lack of knowledge can be sometimes, so right, the drowning prevention education knowledge could be possibly one if people didn't know about that, but that's something that I think most people probably understand pretty well, and it isn't likely why people weren't doing it. But that very well could be if that's what your study showed. But the piece of the article is saying that this one here is, right, the knowledge on the strategy on how to counsel it, how to talk about it, as well as then that collaboration, having families buy into it is really what they were thinking was going to be their bigger one. But I think the drowning prevention knowledge could be considered one, but guidelines themselves shouldn't typically be key drivers, right? That's not why you're having results not happen. It isn't because the guidelines there. All right. So here are the references I had. I think we have just a couple more minutes. Anyone else? Any other questions? The other thing I think that when I was talking with Dr. Fulton about this too was that looking at the study, right, it's a pretty simple, straightforward study that they did, right? They didn't have to reinvent the wheel or do anything too crazy, and yet they were able to get published in, the Pediatrics journal, mailed out to everybody. So, QI doesn't necessarily have to be this huge project where you come up with a radical new idea to target things. You can target very common bread and butter topics in pediatrics in pretty simple ways, right? They gave you didactics, they worked on making the EHR a little bit easier for them, and then had follow-up with them. So QI doesn't have to be a huge, research project where you're doing a full clinical trial and all of this stuff. It can be focusing on the things that you do every day, and pretty simple interventions can sometimes make a pretty big difference, which I thought was pretty neat to see. Alrighty. Any other questions, thoughts?
I agree, David. I went to a conference on this about QI publishing, and the research into that is totally different than what you probably were brought up, and a lot of us with the bench research and regression models and multivariate analysis and that showed that to be SC charts and being able to show good run charts with your data. That's what they're looking for in those subsets of the journals for QI publishing. And so it would be worth, if you're doing something like that in QI, is learning how to do those charts. Carilion will pay for you to have what's called QI macros. It's an add-on to your Excel, into where you can run all sorts of U charts, G charts, run charts, and everything, and it'll do the statistics for you. It's very easy to use, and they have good their technology support folks are real good. But Carilion has paid for it in the past, and it's available to you guys. You would just it would be through the IT, and then it would be an Edison request from how I was able to get it. But it would be something to look into if you're interested. And I can talk more about it if need be. Just message me.
That's awesome. Thank you, Dr. Ward.
Yeah, good work, David. This was interesting.